here to evaluate the long axis of the infraspinatus tendon. So counting our layers underneath here, we've got glenoid, femoral head, here's that posterior labrum, and then let's watch this joint capsule under the infraspinatus kind of unfold itself. I'm going to keep our patient's elbow down to her side here, and then she's just going to slowly externally rotate, and let's watch this joint capsule unfold. Here we go, right there. And then let's internally rotate. Okay, and then it's folded and tightening over the articular hyaline cartilage of the humerus. Now let's externally rotate again. And this is where I'm looking for debris, calcium deposits to pop out of there, loose bodies, all kinds of things can just be shoved into this joint recess. But you can see that little fold right here, and it's a normal joint. And then internally rotate. That's where we would see a big joint effusion. And then just relax. Good. After our long axis plus that dynamic evaluation, I typically switch over to a short axis evaluation of the posterior infraspinatus. And by just going over the scapula here, that infraspinatus fossa, I think it's the easiest to obtain the short axis image. So I'm just going to go transverse, and I have the left side of the screen facing superior up towards the spine of the scapula, which is here. So here's the spine of the scapula on the most upper screen left, and you can see where the infraspinatus begins right here, this whole corner. We're just going to follow it down all the way to here, and then that's that inferior glenoid right there. So that's about where you would stop visually evaluating infraspinatus. So all of this is infraspinatus. It's a multi-pinnate, kind of a tripinnate muscle. So we see three different heads here very distinctly. Then the central tendon is still forming here. So it kind of looks like a tree. I've always kind of told myself that it looks like a tree top here. The more proximal you go, and then the more lateral you go, it tapers together and becomes that central tendon. A lot of times it gets caught under the acromion shadow and you can't see it. That's when we have our patient reach up and grab the opposite shoulder there, and you actually saw the infraspinatus roll out from under the acromion. And then I'm going to adjust my depth. There we go. And then let's just follow that anterior edge here. You can see the leading edge of the infraspinatus before it makes its way to the supraspinatus in this case. So I'm just following that, looking for involved tears that may involve infraspinatus and supraspinatus. Typically, you don't normally see an isolated infraspinatus tear, although I've seen a couple. It's just pretty rare to see just an infraspinatus tear. They're usually involved with supraspinatus as well. So let's follow this transverse infraspinatus posteriorly again and just check our work and go all the way down to its proximal musculotendinous junction. Drop my depth just a few clicks. And then here's that central tendon again. And I'm looking for atrophy of either of these muscle heads, any of these three groups. I need to see hypoechoic muscle out to this outer rim of fascia around the muscle. I don't want to see a grainy, thickened appearance around the muscle that would indicate some sort of fatty atrophy. Same with the supraspinatus exam. You would want to compare this muscle belly, for example, either with the teres minor, which we're about to segue into, or you can climb up north on the shoulder and compare the infraspinatus muscle belly to the supraspinatus muscle belly and make sure they look similar in echotexture. So here's our spine of the scapula now, and then here's our clavicle anteriorly. Okay, and now we see the trapezium superficially and the supraspinatus muscle deep. And I need that supraspinatus muscle to also look like the infraspinatus. It needs to have a nice hypoechoic echogenic appearance all the way out to this fascia. And then I'm just going to fall over that spine of the scapula posteriorly and compare its texture and thickness to the infraspinatus. So carry that into your clinical exam if you're curious about fatty atrophy. Fatty atrophy will look like a grainy rind around this cross section of the muscle. And you'll almost see the outer edge of the muscle taper in and look exactly like this tendon. So there won't be this hypoechoic normal gap of muscle, for example. I'm going to use this view to get us down to the teres minor. So the way I like to show people to do teres minor, because this can be a bit confusing, is go ahead and relax the shoulder. Good. And once we're over that humeral head, then follow the humeral head to the head-neck junction, kind of like you would a hip. When we did the anterior hip webinar, we had a landmark of the head-neck junction for a hip injection. In this case, you're going to get a very similar view, and that's going to be for isolating and locating the teres minor, so that it's easy for you to compare. So here's that humeral head, neck. This is all teres minor here, muscle belly. Okay. And then right here is the central tendon. It's a bit superficial compared to the infraspinatus, for example. And what I'm going to do now is, just like in the PowerPoint, this being my home base view, I'm going to go laterally to its insertion on the inferior facet. There, you can see it not up above my arrow. That's still some infraspinatus involvement. This is the facet that I'm talking about. This is the teres minor. You can even see those little musculotendinous slips, or the little interdigitated slips, kind of like we see in a subscap. I don't know if that's going to be real easy to see on Zoom, but what I can do is zoom in on that so that you can see the detail of those little tendon bundles there. So here we see very nicely individual little heads of the teres minor right there. So I'm going to unzoom. I'm going to back out. Now let's follow proximally until we see another bony landmark. Remember, I'm scanning the surface of a cylinder in this case instead of a round ball. And as I go posteriorly, I have to aim back into the cylinder, right? So that's the scanning technique I'm applying here. Still following this muscle belly. Make sure it stays 90 degrees to your beam. It's nice and bright the whole time. There we go. Our next skeletal reference point just went down in depth a click, and bringing up the arrow is the inferior glenoid. So at this point, the inferior glenoid tubercle is the insertion of the long head of the triceps. This makes a really pretty view. So here's the triceps. This is the muscle belly of the teres minor. You can see a little edge artifact casting a shadow here. And then coincidentally, just posterior to that, or inferior to that, is that this is the quadrangular space on this side of the triceps here, where you've got a little axillary nerve impingement that could happen back here, plus the circumflex humeral artery that goes posterior as well. And then we could follow that triangle more lateral to the humerus, where we get the quadrilateral space here. So humerus side of the triceps, quadrilateral space. Medial side of the triceps, quadrangular space. And using the triceps and the teres minor as a border to do that evaluation is really nice. So why do we take this image here? So this is your evaluation image of the teres minor and the infraspinatus in the same shot. With this larger linear footprint transducer, it's 50 millimeters. We're able to capture, for the most part, the entirety of the infraspinatus muscle belly and the teres minor muscle belly in one shot. And we want to say, or be able to say, that the teres minor is approximately 1/3 the size of the infraspinatus. If the infraspinatus and teres minor are the same size, you really need to be looking at why is there either hypertrophy of the teres minor or atrophy of the infraspinatus. All right, so we've done the short axis of the teres minor. I'm going to go back to that head-neck junction view, and I'm going to rotate the left side of the screen medial, and we'll go over the scanning tips for the long axis of the teres minor. So there's our enthesis of the teres minor right here on that inferior facet. There, we can see its enthesis really nice here. And as I go more proximal, if I don't see a nice bony backboard of a landmark down here, what you want to do, because we're scanning, now we're on the ball of the humeral head, right? You're going to want to drop the transducer inferiorly and aim up, because we're scanning the surface of a ball. Remember, we need to aim up into the ball And the goal here is to pinch that teres minor tendon between your transducer and the humeral head. That way we have a skeletal reference point in the image. So by doing this really sharp angulation upward here, move my big hand out of the way for the camera, we can see the central tendon really nicely. We can see the posterior glenohumeral joint, and we have a nice skeletal reference point to follow. So I'm going to have our patient just slowly externally rotate, and that brings the enthesis of the teres minor. And let's just hold that position, and I'll point it out. Let's internally rotate just a bit more. Let's follow that enthesis here. Here's your enthesis. And then internally rotate a little more, right about there. And we can get both the glenohumeral inferiorly with the labrum and the teres minor all in that one shot. But look at the extreme acute angle I'm having to take to get that. You don't want to just follow the skin surface for this, or you might get a little lost in the soft tissue. You really do need to angle up to get that really nice glenohumeral joint. And let's internally rotate again. And there's our muscle belly with central tendon going proximally. And then lastly, following that glenoid tubercle, posterior glenoid tubercle, more proximally, let's look at the spinoglenoid notch, which I should have covered in the normal glenohumeral exam earlier. Here's our humeral head, posterior glenoid tubercle, and our infraspinatus fossa. If you're looking for the spinoglenoid notch like you saw in the PowerPoint, the only trick here that I recommend people do is plant the lateral side of the probe, and then you're going to pivot the medial side of the probe up north towards the scapular spine. So I'm just going to set my finger here as a pivot, and I'm just going to aim north. When I do that, I deepen that spinoglenoid notch, and then we can see, move the arrow, here's what we're looking at, this divot here, this is spinoglenoid notch. So just as a review, we have humeral head, posterior glenoid labrum, posterior glenoid tubercle, and now we're in the spinoglenoid notch, which is holding our suprascapular nerve posteriorly. There's also an artery and a vein down in there. And just to show the vein, what I'm going to have our model do is just slowly externally rotate, and you're going to see this vein dilate here. So that's normal. Go ahead and relax. If they're already in an external rotation, let's say, go ahead and externally rotate and just hold it, and you're doing this exam, and you fall into that spinoglenoid notch, don't call this big hypoechoic structure a cyst. This is not a paralabral cyst at this point. It's just that dilated vein. And certainly don't throw a needle in there. Go ahead and relax, and you'll see that vein collapse. So just know that that is where we're looking for the posterior suprascapular nerve back here. There are those other neurovascular structures in the area too. So if I were looking for a paralabral cyst, sometimes they dump from the 9 o'clock labrum back here. But for the most part, from what I understand, they also can happen in the superior labrum and drop down into this notch. So you may not see the stalk of the cyst back here. It may be that this is a superior labral tear that has dumped its cyst down this notch. So that cyst can just pool down there instead of it being something that you see originating from this part of the labrum. So if you do see a cyst there, but you can't find the tail, obviously you're going to need to have an MRI anyways to see the extent of the labral tear, but that is what you should be aware of also. That is the posterior shoulder from a rotator cuff and standard evaluation minus the axillary nerve involvement back there in the quadrilateral space, quadrangular space. But from reviewing the infraspinatus tendon as a rotator cuff structure and the teres minor as a rotator cuff structure, those are the standard things to look for. I would say the teres minor is very forgotten in the shoulder exam. Almost nobody looks at it. So if it's not a part of your normal protocol, I would say it's normal for it not to be a part of your normal protocol. But don't forget about it, because sometimes you do need to measure it against the infraspinatus. And it is a requirement in the AIUM protocol for shoulder exam. So you shouldn't skip it. You should at least get the two views, long and short axis of the teres minor, as a part of your routine shoulder exam. But that will conclude today's webinar on the posterior shoulder. If you have any questions, go ahead and just type those in the chat portal while we're waiting on those questions. Don't forget, next webinar is over the superior shoulder, where we're going to cover AC joint, some dynamic maneuvers here, and some other surrounding structures after the basic shoulder exam of the AC joint and its dynamic maneuvers. We'll also cover some of the surrounding muscles and nerves and answer your questions live like we always do.
All right, as Daniel said, it is time for Q&A. If you want to, you can put your questions in the Q&A box located at the bottom or the side of your screen. Just go ahead and type those in there, and we'll go ahead and get to those as we get to them. Daniel, do you have anything that you would like to add on to what we saw? What we just saw?
You know, that was a pre-recorded webinar that took place in 2021, and since then our patient has had a shoulder injury that we actually mentioned on the last webinar. So her left shoulder has been operated on. So a little interesting change in the landscape here. So I'll point a few of those things out. Seemingly normal labrum at this slice here, but as I go more inferior, we start to see an anchor site divot in the humerus. And then if I go even more inferior, we'll start to see the sutures in her labrum down here, where she's had a inferior capsular repair. So she's got anchors in the front of her shoulder and the back of her shoulder, but these are deep sutures down here, right where my arrow is. And anytime you're evaluating things that have been healing over time, it's always a good idea just to check for new blood flow, neovessels. So I'm going to do that today. I'm going to press the C button here on the Sonosite PX, and we're going to look for new blood vessels that typically don't traverse down into the labrum. So very light pressure. You don't want to push down too much. And we have some normal arteries sitting back here in that suprascapular notch, which is a great place to calibrate your color, actually. So while we wait on questions to come in, just listen to some scanning tips on calibrating your color. If you don't see the suprascapular artery back here, you might want to consider changing a few settings on the screen. You may consider turning your gain up a little bit. Pulse repetition frequency or scale needs to be down low enough to see low level flow. There we go. Other consideration is go look for the wall filter on your machine, which is like a noise suppressor. And you want to make sure the wall filter's fairly on low, but it's going to subject your transducer to a lot of tissue motion as well. So on the Sonosite PX, I find that I get away with a medium wall filter very nicely on the MSK exam type. And I'm gonna track these arteries, and we're gonna follow one or two of them down into that labrum, which we don't normally see. So kind of like a cooking show. I've previously scanned our patient today, and there we go. You can see that little offshooting artery. Let's get my arrow back up. We're gonna watch this one little vessel feed off. There it goes. Real steady hand. And that is kind of a new communication into the labrum, and we can follow that all the way down into the anchor site a lot of times. You always want to be very suspicious of color activity next to bones, because these little flashes are most likely just the tissue motion really fast against a hard specular reflector in ultrasound. So what we're looking for are these teeny tiny little blood vessels to be in areas we don't normally see them, like we saw that first artery making its way over into the majority of the labrum there. There we go. But open for the questions. Chris is on the chat portal, and he can ask those live. Let's get a new external rotation on our patient, because those sutures definitely take a little bit of a different look. So let's go external. There we go. And then internal. You can see that divot site where the anchor is. Right in there. And externally rotate. Very good. Superficially on our patient today, we can see a portal. Get our arrow highlighted. So this little divot in the skin, right there, that dark shadow, that's one of her scope portals. So it was interesting to see that heal over the course of a year. and it had its own little neovessels associated with it. And then we have another stroke portal right up here where there's kind of a shadow at the skin level. Where is that? They're fairly obvious once you go over them. Yeah, a little lower. Okay.
Are there any other injuries where it's helpful to have the color on?
Yeah, you bet. So even if it's not an acute injury, chronic disease, chronic tendonitis can also show up that way. We should not see those vessels inside tendons. So in a normal tendon, we don't see the vessels. So if we just wanted to check out for some sort of a tendonitis, you want an appropriate depth on your machine, fairly centered, so all your focus is in the middle, and then we're going to throw the C button again for color, and we should have a pretty healthy tendon here. These fibers look normal, longitudinally striated. I don't see any swelling in the fibers like a loaded paintbrush, so I don't see a tendonitis look. I don't see a degeneration of the fibers either. So the fact that I'm seeing nice striations is just telling me that we have a healthy tendon here. If it were diffusely dark, what we call hypoechoic, and I lost the fibrillar pattern of the tendon, but the shape of the tendon was still there, we'd start looking into things like tendinosis, which, depending on its stage, can also have hyperemia or the neovessels within the tendinosis as well. So mainly it's those, and also to avoid structures when you're doing procedures in the shoulder. You imagine the injections around that quadrilateral or quadrangular space. You might want to miss the artery and the nerve if you're just trying to free one up, like a hydrodissection where you get in there and infiltrate the whole space with saline and really free everything up. You'd want to have your color turned on for that as well. So say we wanted to miss the vessels in this quadrangular space here, we could drive a needle right into that little triangle, maybe even use the left-right side, so we can drive the needle on screen right without all the tissue motion associated with the needle moving, and we can see the artery really, really nicely, what we're going to try to miss. Or you can go top-bottom and have the whole transducer, just a smaller field of view on the screen. But it's very helpful in procedures to run color alongside your needle, because it can be a minefield in there. Great question.
Yeah, we've got another question coming in. What is the approach for posterior GH steroid injection? Okay,
so I get this question a lot, and it depends on your subspecialty, I think. I think a lot of people are just trained to go and palpate right underneath the acromion process and drive their needle towards the coracoid. I've even seen people drive the needle down in there and then turn the humerus to see which bone they're hitting with the needle. You don't have to do that with ultrasound. You now can visualize your approach. So instead of going straight in 90 degrees to the joint, which would be the blind approach, and it is a slightly shorter approach, and that's fine. We're going to come out more lateral so that we can slide the needle right under the joint capsule. So the most traditional approach by ultrasound guidance that's taught throughout the country really is to bring your, and what I will say from a technical standpoint is if you have too much humeral head in the shot, like say this is a great diagnostic picture, okay? All our landmarks are there, it looks really pretty. But if you come in from lateral and you're trying to get into the joint here, you're probably going to hit the humerus first. So my tip for you is to put half the humeral head over on screen right. There you go. So that way, when you drop your needle in this way, you'll see your needle, and I'm just going to freeze because our patient definitely will not let me drop a needle in there. There. And then I'm going to hit caliper, and we'll simulate our needle trajectory. You can stop the needle at the tip of the labrum under the joint capsule, right where that caliper is, at about that trajectory. And that's coming in at about, 30 degrees or so. And you want to be right under that long axis of the transducer. There's a factory seam on the transducer typically. And if you just drive your needle right under that, align your syringe handle with the seam at the top of the handle, and you should stay in plane with the transducer. That's the most traditional approach by ultrasound. I also see it taught to go the opposite way in a lot of parts of the country, depending on your specialty. And I see a lot of sports guys going this way. So basically bringing your target more screen left. I'm going to hit freeze, and then they would drop their needle right through the edge of the labrum and just give it a little puncture, which, you know, I guess if that's what you want to do, you can drive your needle through a little bit of the labrum. I guess no harm, no foul, but for me, why would you want to hit the labrum with a corticosteroid, which could degenerate the connective tissue if you're trying to avoid surgery down the road, you know? But those are the two main approaches. And then less commonly seen, but I think it's more an adaptive change for people, is they'll center the joint and do something like centerline on their machine. And right under that arrow on the transducer, they'll go out of plane. You just got to be real careful not to overshoot. And you're definitely going to go through the labrum on this one and drive the needle out of plane this way. What you need to be careful of is if you're going under, depending on how your patient's positioned, if you go under the probe like this, you may have gel coming into your needle puncture site. So you don't want that. You want your transducer to be under the puncture site. But that's pretty common, but I think it's just an early adoptive phase of doing these injections to go this way. The more familiar you get with ultrasound, the better you get with positioning your patient. It's more common to put them into a lateral decubitus position with the affected shoulder up and the patient facing you. Just have them hug a pillow, and that puts you in a really comfortable ergonomic position this way. So you're not trying to do this or do any trick shots. If you could set the patient up in a way that they're always set up like a knee injection, where you get to hold the probe real comfortable and just drive the needle in the same angle every time, rotate and set up your patient that way too. So I would have our patient on the table, lay them lateral decubitus and affected shoulder up and body facing each other. That way the glenohumeral joint is facing my needle. And I can just come in screen right, drop the needle down, not quite 45 degrees. Great question.
Awesome. You said that the recorded part was from, what was it, 2021? Are there any kind of more up-to-date techniques or anything like that you've learned in that time?
You know, there are more advanced diagnostic structures that go beyond the scope of this webinar, like some of the other kind of crazy ligaments in the shoulder that are beyond traditional diagnostics. Some of the inferior glenohumeral ligaments are not traditionally scanned. There's not a lot of protocols for that, but it is something that, you know, with my patient here having the shoulder surgery she had, I got to learn a lot about those posterior, inferior glenohumeral ligaments and the anterior, inferior glenohumeral complex and that whole axillary scanning fold. That would be a whole webinar in its own, just to go through the axillary recess and those connective tissues, how to navigate around neurovascular structures, looking at ligaments in normal and abnormal, and even torn, which is what we have here. So I would say I got to learn a lot about the remaining ligaments that stabilize the shoulder. And I've always been fascinated with postoperative changes in shoulders and anywhere else in the body, but shoulders is just so common to get postoperative scans. So if you've kind of plateaued on your diagnostics with ultrasound of the shoulder, I would say to venture off into post-surgical shoulders. That'll pique your interest. Trust me. And there's so many different ways to repair a shoulder. I would study the orthopedic hardware companies' websites. You go to their animated videos and some of their intraoperative videos on their websites, and they'll walk you through step by step how these surgeries are done, where the anchors go, why they do it from a mechanics standpoint. And that helps me go chase things down, like those inferior, posterior glenohumeral ligaments. You know, if I didn't know that they were relatively going straight up and down on the shoulder posteriorly because of how they hang the humerus from the glenoid, I might spend way too much time trying to chase the ligaments down, thinking that they just bridge the gap transversely when they don't. These posterior and medial inferior ligament complex, they don't traverse the joint sideways. They really hang down and hang on to the rest of the undersurface of that humeral head like a big hammock. So the direction of the ligaments, you know, it really didn't click to me until seeing these things intraoperatively and through a lot of the training resources of the orthopedic hardware company's videos. So that would be the best learning tool for post-operative anatomy, would be to find out why these surgeons are doing what they're doing with their anchors and sutures, what kind of sutures they are. Hope that helped. Ligaments of the shoulder, I would say, is probably the thing that has changed for me the most since then. But rotator cuff protocol hasn't changed since about 1999. Middleton is the article that you would look up. Bill Middleton or William Middleton, do that search on rotator cuff ultrasound protocol, and that protocol has become the standard AIUN protocol. And it's such a rock solid protocol because the imaging technology they had in the late 90s was far inferior to what we have now. So what we have now makes the imaging much easier. Their technique had to be a lot more solid because the machines were a little less capable in resolving the tissue. Their beam had to be much more perfect in their slices. So we're pretty spoiled on our image quality now and our training resources. But if you go study the article, especially from Middleton and Teefy, I think it was published in 1999 in the American Journal of Radiology. That's the foundational rotator cuff article that we still use today, and it's what the AIUN protocols are based on. So there have been no new advances to shoulder protocol as we know it, and what should be covered since we did this video in 21. No, but we're never done learning. That's for sure. Anybody that's doing ultrasound in the chat can tell you that. No matter how long you've been doing this, you're never done learning.
All right. Well, I don't see any more questions coming in. Okay. So just a reminder, we'll be rerunning the fourth part of the shoulder webinar series on the superior shoulder on January 16th. It'll be at the same time as it is today, 6 p.m. PST. We'll also be announcing some more webinars soon, so keep an eye on Behind the Scan webinars page on sonosite.com for more details on that. Daniel, I'd like to thank you for taking the time to put together the original presentation and coming back and doing the Q&A again. We appreciate you sharing your expertise with our audience. And everybody else, thank you so much for joining us today. We really appreciate it, and we'll see you at the next one.
Thanks, everybody.